Here we will learn the major spinal cord disorders and in the process solidify our understanding of spinal cord clinical anatomy. Start with the table. We'll keep track of the disorders at the top and take notes on the cases at the bottom. Case 1. Patient presents with a few-month course of trunk and lower limb sensory dysthesias. Exam reveals hyperreflexia throughout except for absent ankle jerks, pathologic, meaning positive, Babinski's, loss of vibration proprioception sensation in the lower extremities with preserved pain temperature sensation, and mild diffuse lower extremity weakness. Show that the loss of vibration proprioception sensation with preserved pain temperature sensation suggests posterior column involvement. Then show that the diffuse motor weakness is due to corticospinal tract involvement. Indicate that this combination of deficits is often found in subacute combined degeneration due to vitamin B12 deficiency. Case 2. Patient presents with an abrupt onset of interscapular pain, lower extremity weakness, sensory disturbance, and bowel and bladder incontinence. Exam reveals areflexia of the lower extremities, periparesis, loss of pain temperature sensation with preserved vibration proprioception sensation in the lower extremities, anal sphincter atonia, and a normal motor, sensory, and reflex exam in the upper extremities. Show that the sudden weakness and areflexia suggests bilateral anterior motor horn cell involvement, and that the longitudinal loss of pain temperature sensation suggests involvement of the anterolateral system with preservation of the posterior columns. Indicate that this constellation of deficits suggests anterior spinal artery ischemia, in which the anterior two-thirds of the spinal cord are affected. Note that this syndrome variably affects the lateral corticospinal tracts. Case 3. Patient presents with sudden weakness on the right side of the body and sensory disturbance. Exam reveals right side weakness, right side loss of vibration proprioception sensation, and left side loss of pain temperature sensation. Reflexes are absent on the right side and normal on the left. Show that the right side hemibody weakness suggests right side corticospinal tract involvement, that the right side loss of vibration proprioception sensation suggests right side posterior column tract involvement, that the left side loss of pain temperature sensation suggests right side anterolateral system involvement, and that the right side areflexia suggests right side lower motor neuron involvement, which could occur from either anterior horn injury or posterior horn injury. Indicate that this constellation of deficits suggests a hemicord syndrome involving the right half of the spinal cord, called Brown-Séquard syndrome. Case 4. Patient presents with a few-month course of progressive burning pain across the shoulders. Exam reveals weakness of the upper extremities, absent biceps reflexes with hyperreflexia of the lower extremities, pathologic, meaning positive Babinski's, absent pain temperature sensation across the upper chest and limbs with preserved vibration proprioception sensation. Show that the dissociation of loss of pain temperature sensation with preserved vibration proprioception sensation in a suspended sensory level suggests damage to the crossing anterolateral system fibers. Show that the loss of strength and areflexia of the upper limbs in that same segment suggests bilateral anterior motor horn damage. Indicate that this constellation of deficits suggests a central cord syndrome, often a syringomelia. Case 5. Patient presents with a several-month course of weakness that began in the left arm and has since spread to both arms and legs. Exam reveals asymmetric but diffuse upper and lower extremity weakness. There is mixed hyperreflexia and areflexia throughout the bilateral upper and lower extremities. There are bilateral pathologic, meaning positive Babinski's. sensory exam is normal. Show that the presence of motor weakness in conjunction with mixed hyperreflexia and areflexia with bilateral pathologic Babinski's and a normal sensory exam suggests both corticospinal tract and anterior motor horn involvement. Indicate that this constellation of deficits is often found in amyotrophic lateral sclerosis, also known as ALS or Lou Gehrig's disease. This ends our essential material. Case 6. Patient presents with years of progressive lightning-like pain in the lower extremities. Exam reveals profound lower extremity loss of vibration proprioception sensation with preserved pain temperature sensation and preserved strength in the lower extremities. There is areflexia in the lower extremities. The upper extremities are normal. Show that the loss of vibration proprioception sensation with preserved pain temperature sensation and preserved motor function suggests posterior column spinal cord involvement. The lower extremity areflexia suggests lower motor neuron involvement, so also show that there is dorsal root involvement. The dorsal root involvement causes the lancinating pain, presumably from irritation of the pain temperature fibers. Indicate that this constellation of deficits suggests a diagnosis of tabes dorsalis, also known as syphilitic myelopathy, in which the posterior columns and dorsal roots are affected. Case 7. Patient presents with muscle pains and slowly progressive muscle wasting. Exam reveals asymmetric lower extremity weakness, hyporeflexia in the lower extremities, the absence of pathologic Babinski's, meaning negative Babinski's, and normal sensation. Show that the weakness in conjunction with hyporeflexia in a normal sensory exam suggests anterior motor horn involvement only. Many illnesses cause select anterior horn cell loss. Indicate that two common illnesses that cause this pathology are spinal muscular atrophy and polio syndrome. Case 8. Patient presents with slowly progressive lower extremity weakness. Exam reveals spastic weakness of the lower extremities more so than the upper extremities. Hyperreflexia, bilateral pathologic, meaning positive Babinski's, gait ataxia, and a normal sensory exam. Show that the weakness in conjunction with spasticity, hyperreflexia, bilateral pathologic Babinski's, and a normal sensory exam suggest corticospinal tract involvement. Indicate that select corticospinal tract involvement suggests a diagnosis of primary lateral sclerosis. Case 9. Patient presents with long-standing gait disturbance and weakness. Exam shows lower extremity areflexia with preserved upper extremity reflexes, pathologic, meaning positive Babinski's, profound ataxia, vibration proprioception sensory loss out of proportion to pain temperature sensory loss, and motor weakness of the upper and lower extremities. Show that the mixed reflex pattern in the presence of pathologic Babinski's suggests a mixed upper and lower motor neuron disease pattern with pathology of the dorsal nerve roots and dorsal horns. Then show that the vibration proprioception sensory loss with preserved pain temperature sensation suggests posterior column involvement. Next, show that the profound ataxia suggests spinocerebellar tract involvement. And finally, indicate that the motor weakness suggests corticospinal tract involvement. Indicate that this constellation of deficits is found in Friedreich's ataxia, an inherited progressive ataxia with pathology that first appears in the dorsal roots. Spinocerebellar tract involvement is an important distinguishing feature of this disorder. This concludes our diagram.